Hello and welcome back. For those of you who need a reminder, my name is Miss Bree. Welcome to the Practicum 1 Certification Review session number 2. I am going to share my screen and we're going to get started on the lesson. Okay. Make sure that I pull it up correctly. There we go. Come on. Okay. So again, this is Practicum 1 session number 2 for certification. The packet to accompany the certification review number 2 is on Blackboard under the Student Resources folder in the certification review sessions folder. And again, we are in review session number 2, so please download and either print out or access them via another device and have them ready so you guys can follow along with the session. Just to recap, we talked a lot last week about test taking strategies. We are going to be using those again this week. So step-by-step basis, we're going to read the question in its entirety, slow down, take a deep breath, make sure that you try to answer it as best you can in your head before you start looking at A, B, C, and D. And then yes, you are going to read the question one more time, making sure that you understand the question in its entirety, making sure you identify any of those key words like all of these are true except, everything applies, but just making sure that you understand exactly what the question's asking. Then you're going to get to a 50-50. Discard at least 2 options so you give yourself a better percentage chance of making the most educated guess that you can, and then answer your question with confidence. Do not go back and second guess yourself. You already did the test taking strategies. You should be confident in your answers. The only reason that you should ever change your answer is if you realize that you didn't understand the question fully. Okay, so let's get started. Our learning objectives. We're going to talk about OBGYN surgery. We're going to talk about the anatomy and physiology first, and then we're going to talk about intraoperative procedures after that. And then the accompanying lesson is going to be on equipment sterilization and maintenance. Okay, so let's get into the OBGYN surgery, anatomy, and physiology review. We are going to do our test taking strategies together for question number 1, and then I'm going to let you take it from there. Okay, so let's get started, and I'm going to exit out of presentation mode really quickly, scroll, make this a little bit bigger so we can all do this together. Okay, so the first question, which layer of the uterine wall lines the uterus, the fallopian tubes, and cervix, which sloughs off during menstruation? So I'm going to think about this really quickly. I'm going to digest that question, take a deep breath. Don't look at A, B, C, or D yet. Sometimes I'll even cover it. Come on. Sometimes I'll cover it. I promise this will help. Goodness me, if I can actually do it correctly. There we go. I'll cover it. So thinking about the uterine wall, now remember in class there were 3 layers to the uterine wall, so I'm likely looking for one of those 3, and we're talking about the uterus, the fallopian tubes, and the cervix. And if I remember about the anatomy of the female reproductive system, all of those 3 structures are continuous with each other. The cervix, the uterus, and the fallopian tubes all share the same structure. They're just different parts of one whole piece. It talks about menstruation. Trying to think about what I know about menstruation. It's usually a 28-day cycle, depending on the person. And the lining of the uterine body is going to slough off because a fertilized egg has not implanted into that lining. And that's why it sheds and starts to rebuild next month. So in my head, remembering what I know about the uterine wall, from inner to outer, the med term for inner is endo. The med term for middle is usually medio, but I also remember the uterine wall needs that really thick layer of muscle. And I remember the uterine muscle needs to contract for menstruation and for delivery. So I remember the word myo means muscle in midterm. And then there are a lot of words that we can think about for the outermost layer of a wall. I know there's 3 layers. So there's an inner, a middle, and an outer. So the outermost layer, there could be a lot of words at play. There's exo, there's peri, which means surrounding. Adventitio usually means outer. Extra or extro or ex. Yeah, so thinking the innermost layer is going to be endo. So that's what I would go with if it were me. So I'm going to uncover this and I'm just going to confirm. I'm going to reread this one more time. Which layer of the uterine wall lines the uterus, fallopian tubes, and cervix, which sloughs off during menstruation? Okay, so endometrium's on there. I'm going to clock that as my potential answer, but I'm going to look at the other answers and at least get it down to a 50-50. So endometrium is A, myometrium is B, perimetrium is C, and peritoneum is D. So everything that we talked about in terms of the structure of the uterine wall makes sense here with our A, B, C, and D, and endo, myo, and peri. So peri is going to be the outermost, so I'm going to get rid of perimetrium. And then I'm going to also get rid of the peritoneum because I know that the perimetrium is a reflection of the peritoneum, but the peritoneum usually refers to the lining of the abdominal cavity. So I'm going to get rid of that as well because it's not exactly talking about the uterus. So our 50-50 is endometrium and myometrium. I'm going with endometrium as my final answer. And then I'm going to show you guys that I am in fact correct. And the menstrual cycle, as you can see, essentially what's going on in the uterine cycle or the menstrual cycle is the endometrium will, for lack of a better term, it will beef up. It'll get ready for the potential implantation of a fertilized egg and sperm combination. So that implantation is going to trigger the growth of that combination of egg and sperm into a fetus eventually. But that's where the implantation is going to be in the endometrium. So if the person in question does not have a successful implantation of a fertilized egg and sperm during the menstrual cycle, that endometrium will shed during menses and will regrow, get beefed up again. And then if the next month it doesn't receive an implantation of an egg and sperm combo, it'll do the same again. Just rinse and repeat. So if you guys need a little bit of a better picture of the uterine body, there you go. You can see the endometrium is here, the inner lining, and you can very much see that the cervix, which is the neck of the uterus, below the uterine cavity proper, and then the fallopian tubes, they all share this connection. So they are all covered by this endometrium. Awesome. And then you can see the myometrium in the middle. That's the muscle, and that's what's going to help the uterine body expel the endometrium during menstruation or deliver a fully grown fetus during delivery. And then the perimetrium is on the outermost layer. And that is a reflection of the abdominal peritoneum. It is its own thing, but it is kind of an extension of it, of the peritoneum. So that's why they call it the perimetrium, because it surrounds the outside of the uterine body. Peri meaning surround. Good. Okay, this is for you guys to answer numbers 2 through 15 on your own using the test taking strategies. Just a reminder, when I say pause, hit the pause button on your video player, answer numbers 2 through 15 on your own. When you've completed numbers 2 through 15, you can hit play again and continue watching the lesson. We will review our answers together when the video resumes. Okay, on the count of 3, 1, 2, 3, pause. Welcome back. Okay, we're going to talk about these answers for all of these questions, numbers 2 through 15, OBGYN, anatomy and physiology. Let's go. Number 2, which ligament helps to suspend the uterus anteriorly? My 50-50, I know uterosacral, utero meaning uterus, and then sacral meaning the sacrum, pertaining to the sacrum, which is in the spine. That's going to help suspend the uterus posteriorly, so that one's gone. And then I know the broad ligament, it's kind of that bat wing. I'm going to pretend I'm the uterus for a second and my arms are the fallopian tubes. The broad ligament almost looks like a big cape. I call it the bat wing, and that's going to be lateral. I know that for certain. Broad is lateral, so I'm going to get rid of broad. So my 50-50 would be cardinal and round. And I know when I was pregnant, and you can use this to your advantage. If you've had a pregnancy before, you might have had round ligament pain. And I always think of round ligament pain is because the pregnant or gravid uterus is getting bigger anteriorly, and the round ligament hurts sometimes. And that's called round ligament pain. If you have experienced a full-term pregnancy, you might know what I'm talking about. So I'm going to go with the round ligament, and I'm correct. You can see it in this picture here. And I don't know why they color it purple, but here we are. The image here, you can see the anterior uterine suspensory ligaments are these round ligaments, these two in the front here. And you can see it a little bit easier too in this picture, and they color it in red in this one. But you can see the anterior suspensory ligaments are the round ligaments. The cardinal and the broad ligaments are going to be lateral. And then you can see here in white, connecting from the uterus to the sacrum, those are the uterosacral ligaments, and those are going to be posterior. So anterior in the front is going to be the round ligament. The suspensory ligaments laterally are going to be the cardinal ligaments and the broad ligaments, and then posteriorly, the uterine suspensory ligaments are going to be the uterosacral ligaments. Okay. Number 3, which structure in the brain stimulates the development and release of the ova? I know it's not the thymus gland because the thymus is like here. It almost is in the similar area to where the heart is. It's located in the mediastinum. So I know it's not the thymus because that's not the brain. And then the adrenal glands are on the kidneys, on the superior medial aspect of the kidneys. They're kind of on top of the kidneys. So I know that's not it because it's talking about the structure in the brain. So my final 2 answers are B and C. And I know the pituitary gland is often referred to as the master gland. So that's going to be my answer. And that is the correct answer. And I have a little YouTube video, Anatomy Hero. It gives you a really short, I believe the video is about 3 minutes in length, really helps you understand the structures in play and the hormones in play for the the ovarian cycle and the menstrual cycle. So please watch that if you have questions or if you're a little confused on the hormones and the structures involved with that process. Okay. The external female genitalia is known as the adnexa, perineum, vagina, vulva. External female genitalia. Okay, so I know it's not the perineum because the perineum is that skin bridge between the external genitals, male or female, and the anal orifice. It's like that skin bridge between those two structures, the genitals and the anus. So I know it's not the perineum. And then I know between vagina and vulva, I know the vagina is internal. That's the canal. I always say the word vaginal canal or vaginal vault so that I know it's literally the birth canal. The vagina itself is internal. So I'm going to get rid of C as well. So I know it's either A or D. You might not be familiar with the word adnexa. I am, because I am the instructor, but I know for a fact that the vulva is the external female genitalia. And if it were me and I'm a student, and I can't remember what adnexa means, but I know what vulva means, I'm going to go with what I know. I know the vulva means external female genitalia. I'd rather risk my answer on something that I absolutely know is true than take a shot at something that could be true, but I'm not quite sure. So I'm going to go with D here as vulva, and that is going to be our answer for any of us who are interested in what the word adnexa means. It means kind of the accessory structures that accompany the uterus. So the fallopian tubes, the ovaries, and their associated structures. So the fallopian tubes, ovaries, those are part of the adnexa. Okay. The first onset of menstrual periods is called. So the first onset, I'm thinking the very first time a patient or a person gets their period. So the first onset. I know it's not menopause because that's the very last one. So C is gone. And then amenorrhea, menarche, menorrhagia. Well, I know a or an, the prefix a or an means without. So amenorrhea means without menstrual bleeding. So I'm just going to assume that that has nothing to do with the first onset because they haven't bled. So I'm going to get rid of A. So I've got B or D. So in this one, say I'm a student and I've heard both of these terms, but maybe I'm trying to like remember. Menorrhagia kind of sounds like hemorrhage or is spelled similarly to hemorrhage. Raj, R-R-H-A-G. I know hemorrhage means excessive bleeding. Like hemo means blood, Raj means excessive. So I'm going to assume, based on what I know about that word, that menorrhagia might mean excessive menstrual bleeding. And that doesn't sound exactly right because not everybody experiences heavy bleeding their first menstrual period. So this is kind of the opposite of the question before, where I knew that vulva meant external female genitalia, and I couldn't quite remember what adnexa meant. In our suspending our disbelief, pretending that I was a student, maybe I didn't know what adnexa meant. So I knew vulva was a good shot at being right. So I went with that. Here, I know A's not right. I know C's not right. So I'm between B and D doesn't quite fit. And if I'm a student and I'm like, I don't know at all what menarche means, but I don't think A, C, or D make enough sense. If you're in this situation and you're fairly confident that 3 of the answers do not make sense, and the last potential option could be the right answer, but you don't know what it is, this is when a good educated guess will come into play, and you could stick with something maybe you don't know because the other 3 answers you know don't fit. So here I would say if I were a student and I was between B and D, I would go with B because D doesn't make enough sense for me. So I'm going to go with B. And I already knew that I was right because, again, I'm the teacher. But just in case you guys don't know what this word means, obviously meno means menstrual blood, and then the word or the suffix arche means the beginning. So that is the very first period that someone experiences is called menarche, and the very last period that someone experiences is called menopause. So hopefully that helps. Okay. Which of the following is an abnormal connection between the bladder and the vagina? So this is, again, another potential to use our medical terminology. Abnormal connection. Well, these are all fistulas. Those are abnormal connections. And then between the bladder and the vagina. So we're looking for those 2 words or medical terms, excuse me. So I know it's not A because anorectal would be a fistula between the anus and the rectum. And same thing with B. Vaginal's in there, but recto means the rectum, and that's posterior to the vaginal vault, where the bladder's anterior, so that wouldn't make sense. So I've got C and D, and I'm looking for vaginal, and I'm going to assume vesico here. If I don't know what the word vesico means, or the prefix vesico in medterm, I know I'm looking for the bladder and the vagina, and I see vaginal in here in D, so I'm going with D. Which is right. So vesico means urinary bladder. So a vesicocutaneous fistula would be a fistula between the bladder and the skin. Cutaneo means skin. So that's why D is our best answer here. Okay, marsupialization is a common surgical technique used to treat which pathology? So marsupialization, I think of a marsupial, which a marsupial is like a kangaroo. There are other marsupials. That's the most commonly referred to one when you think of a marsupial. Marsupials are known and categorized by having a pouch to carry their babies in. So the word marsupialization means to create a pouch. I remember that from class. And so we're just talking about why we would create a pouch for which of these potential pathologies. So we've got a Bartholin's gland cyst, incompetent cervix, venereal warts, and vulvar cancer. I know that for an incompetent cervix, we would put a purse string suture around the cervix to like close it. Bartholin's gland cyst, I know we have to cut and drain and create a pouch. Venereal warts, I know we'd have to obliterate that tissue, either with ESU or laser, radiofrequency ablation, some sort of way to completely obliterate that tissue. Venereal warts, we just burn it off. So I'm going to get rid of C. And then vulvar cancer, you would do an excision, some sort of excision. You can do a simple excision, a wedge resection. You can even do a complete vulvectomy. You can do a skinning vulvectomy. There's a lot of different techniques that you might utilize, but they're all going to have to do with removal. I don't think that makes enough sense. So I'm going to take D off the board as well. So my last two options, I'm between A and B, and A makes more sense based on what I know, because with an incompetent cervix, it's essentially you're going to like cinch the cervix closed so the patient can carry a pregnancy to full term without the cervix almost giving way to the weight of a fetus. So that's to treat potential for miscarriage. And I don't think you would use marsupialization for that. No, it's going to be A. A is our answer there. And this is what the pouch will look like after an incision and drainage of a Bartholin's gland cyst. The Bartholin's glands are going to be located within the vestibule, which is within the labia minora, and they are responsible for providing lubrication to the external female genitals for multiple reasons, but that's what it does. And if that pathway gets obstructed in any way, it can create a cyst. So that's where the Bartholin's gland cyst is going to essentially come from. It's just a blocked duct for the Bartholin's glands, and it blows up like a little water balloon, and you have to do an incision and drainage. And then the reason we do the marsupialization is so the actual wound can completely drain, completely heal without the margins of the wound edges coming back together and sealing shut again, which would create a recurring Bartholin's gland cyst. So that's why we're doing that. Okay. Number 8, a malformed ovarian tumor that develops from the germ layer of a developing embryo containing hair, teeth, and sebaceous material is called. Okay, malformed ovarian tumor. Okay, so let's look at all of these. Cervical dysplasia, that's already gone. That's off of my board immediately because we're looking for an ovarian tumor. And cervical dysplasia has to do with the cervix, which is the neck of the uterus, which has nothing to do with the ovaries. So A is gone. Condyloma, leiomyoma, and teratoma. Well, I know leiomyoma. I remember leiomyoma. Myo means muscle, MYO. We talked about that a couple questions ago. A condyloma, that's genital warts. Condyloma. Usually that's the genitals. So I'm going to get rid of condyloma. So we've got C and D, leiomyoma and teratoma. Well, I know from pharmacology, a teratogen is something, usually it's a medication, but it can be anything. A teratogen is going to cause birth defects, like confirmed birth defects. So teratogen, it's got to mean, yeah, malformation. So I'm going with teratoma just based on the med term that I know. And I know leiomyoma talks about muscle. Myo means muscle. And the ovaries don't have muscles in them. I mean, I'm sure there are some, but not, actually, I don't know. I don't think the ovaries have muscles. I might be misspeaking. I don't think the ovaries have muscles. I'm gonna have to look that up. But yeah, no, I think leiomyomas, if I'm remembering right, are smooth muscle tumors. Those are uterine fibroids. That's what leiomyomas are. Those are uterine fibroids because it is a tumor that results from the muscle layer of the uterine wall. That's why it's called a leiomyoma. Leo means smooth. That's right. Leo means smooth, Lieo. So trato means monster or malformed, and then oma means tumor or mass. So a teratoma is commonly referred to as an ovarian dermoid cyst because it does come from the germ layer, which is the dermoid layer. Okay, number 9, the fallopian tube begins at the uterine cavity at a location called the cervical os, cornu, fimbriae, vestibule. Again, the fallopian tube begins at the uterine cavity. I know it doesn't have to do anything with the cervix. It's on the other side. I guess not other side. The fallopian tubes are going to enter the uterine body superiorly. The cervical os is going to be inferiorly. I'm thinking of myself as the uterus. I'm thinking of my body as the uterus for now. And the cervix is inferior and the fallopian tubes are superior. So cervical os doesn't make sense. So A is gone. Fallopian tube begins at the uterine cavity. Well, I know the fimbriae, again, I'm going to pretend my body's the uterus for now, just stay with me. My arms are going to be the fallopian tube. And the reason I like this kind of analogy is because my fingers can be the fimbriae. The fimbriae are going to have that like come hither, trying to coax the egg that's released from the ova, or excuse me, from the ovary. The ova is the egg, trying to get the ova into the fallopian tube. That's what the fimbriae do. So the fimbriae is at the end. We're talking, I'm pretending my shoulder is like where we're trying to locate. Fimbriae is all the way over at the end. So fimbriae is gone. So it's cornu or vestibule. I just talked to what the vestibule was. The vestibule is in the external female genitalia. We talked about that with Bartholin's gland cyst. It's like the area of the labia minora where clitoral hood is superior, and then the inferior aspect is where the labia minora essentially end, and that's where the perineum would begin below it. So that's the vestibule. That has to do with the external female genitalia. So I'm going with cornu. Cornu is my answer. And that's what oh goodness, go back. That's what the cornu looks like. Again, pretending my body is the uterine cavity and my arms are the fallopian tubes. The shoulder right here where I'm pointing at, that's called the cornu, where it's no longer the uterus, but it's the fallopian tube. That's the cornu. And then you have the sections of the fallopian tube. The isthmus is first, and then the ampulla, and then the infundibulum, and then the fimbriae is at the end. And then the word cornu comes from the Latin. That means horn. So it kind of looks like the uterine cavity has horns. That's why it's called the cornu. Okay, which organ is anterior to the uterus? Ovary, anterior. Anterior is in front. So ovary, rectum, spleen, and urinary bladder. Well, I know it's not rectum. We just talked about that a couple questions ago, and the rectum's behind. It's posterior. So rectum's gone. I know urinary bladder's anterior, so that's going to stay. And then ovary's like lateral. So ovary is going to be gone. So it's either spleen or urinary bladder, and I know the urinary bladder is. I don't know if the spleen is or not. So I'm going urinary bladder. And I'm right. That's where it is, anterior. Okay, during gestation, which blood vessels communicate directly between the fetus and the placenta? So during gestation, gestation means pregnancy. And when we talk about a fetus, we're talking about the not yet born baby. And then the placenta is going to be essentially the connection point between baby and mom that's going to supply the fetus with blood and nutrients. So we're looking for that blood vessel's name, I guess, between baby and mom. So amniotic, carotid, umbilical, and uterine. I know the carotid artery is here in the neck, so that's wrong. So B is gone. I would think the uterine arteries or veins have to deal with supplying the actual uterus with blood and not the actual fetus inside. So I'm going to get rid of uterine. The reason I'm keeping umbilical is because I know when the baby's born, you have to cut the umbilical cord. So I'm going to guess that it's umbilical. Amniotic could be because of the amniotic sac, but I feel like because we cut the baby's umbilical cord, that it's literally what's tethering the baby to mom after delivery. So I'm going to go with umbilical. And this is what it looks like, the actual fetus and the placenta that's attached to the uterine wall at the endometrium. And this is what the actual umbilical cord is going to look like, the structure, and then the umbilical vein and the umbilical arteries that are connected. Number 12, the normal presentation of a fetus in which the buttocks or feet are pointing down towards the cervix. Abnormal presentation. So the normal presentation for a baby is called occiput anterior. So I know it's not C because it almost looks like the baby is going to go diving out of the cervix. So occiput is the back of the head here, and that's supposed to be in the front. It's supposed to be like facing out. So that it literally looks like baby's going to dive out of the belly. So I know it's not occiput anterior. And then breech, brow, transverse. I know transverse means instead of vertical, it means horizontal. So transverse is going to be gone because we're looking for buttocks or feet down towards the cervix. And if they're horizontal, neither of those are pointing, neither the head nor the feet are pointing towards the cervix. They're both horizontal. And then breech and brow. I know it's breech. Brow, I remember from class, is like the eyebrows, like the actual eyebrows are coming out first. So it's got to be breech. Yeah, and then that's what the baby's going to look like if they're in breech. So some patients might have a successful flip, an external manipulation of the abdomen to flip the baby. Otherwise, this might be a potential fetal presentation that's going to indicate for a C-section, potential C-section reason. And then these are the other malpresentations that you can see. So normal, quote unquote normal. I hate the word normal. The most common and the most successful vaginal delivery position is going to be occiput anterior, but then there's occiput posterior, face, brow, breech, shoulder. First degree spontaneous laceration occurring during childbirth tears through which layer of tissue? First degree spontaneous laceration. First degree. So I know with lacerations during childbirth, it goes from vaginal being like lowest degree, like first, second degree, and then anal being kind of the worst of the worst, like 3 and 4 degree. So I know it's not anal sphincter, so A is going to be gone, and then C is also going to be gone because we haven't reached those yet because we're only at first degree laceration. And then we've got perineal muscles and vaginal mucosa. So I'm going with vaginal mucosa because I know the perineal muscles start to get torn around like second degree. So I'm going with vaginal mucosa. Yeah, and so the way that I remember this, first degree is vaginal, and that's the only thing that gets torn. Second degree, the vaginal mucosa gets torn and the perineal muscles get torn. So that's two things. That's why I call it second degree. Third degree, the vaginal mucosa gets torn, the perineal muscles get torn, and then the anal sphincter gets torn. That's when we get into that territory. So that's third degree, three things get torn. And then fourth degree, vaginal mucosa gets torn, perineal muscles get torn, anal sphincter gets torn, and then the rectal mucosa gets torn. So that's fourth degree, four things. Thinning and softening of the cervix prior to the delivery of a fetus is referred to as crowning, effacement, gravidity, parity. Thinning and softening of the cervix. I know it's not crowning because the baby's head would be already coming out. And this is prior to delivery of a fetus. Crowning would be happening during the delivery. Effacement, gravity, parity. I remember gravid uterus means a uterus with a fetus growing inside it. Gravidity means growing. And then effacement and parity. So effacement and parity are going to be my 50-50. I'm going to get rid of A and C. And remember cervical effacement meaning like the cervix is ripening and getting ready for delivery. So I'm going with effacement. And that's what it kind of looks like when the cervix is not effaced and when it is. It's kind of like open and completely soft and ready for delivery, vaginal delivery, which is the suspensory ligament of the ovary. Okay, we've got a lot of fun med terms here. Suspensory ligament of the ovary. Okay, so we have an infundibulopelvic, pubocervical, pubovesical, and uterosacral. So we're looking for the ovary. Now, I don't see ovarian or ovary anywhere in A, B, C, or D. One of them has to be right. So let's think of the other options that we have to kind of figure this out. Well, I know pubo, P-U-B, means the pubic bone, which is anterior. It's like that anterior part of the hips of the pelvic bowl met together at the symphysis pubis. That's what pubo means, the pubic bones that are brought together. Each hip bone brought together. The one anterior is going to be the pubic bone, and that's going to be joined together by the symphysis pubis. So pubocervical would mean pubic and cervix. Neither of those say ovary. So I'm going to get rid of B. And then pubovesical. Vesico means urinary bladder. We remember that. So I'm going to get rid of C as well. And then uterosacral doesn't make sense either. Talked about that one being a suspensory ligament of the uterus to the sacrum. So the only option I've got is A. And if you didn't know, now you do. It's called the infundibulopelvic ligament. There is an ovarian ligament more medially, but then the infundibulopelvic ligament suspends the ovary to the pelvic bowl laterally. So the infundibulopelvic ligament suspends the ovary laterally. Okay, we're gonna do a rapid fire through these because it's already 40 minutes and I always promise you guys 45 and I'm always lying. Okay, you have your time. You're gonna pause when I say pause, complete numbers 1 through 15 on your own. Hit play when you're done and then we'll review the answers together. Okay, on the count of 3. 1, 2, 3, pause. Welcome back. Okay, we're gonna just do rapid fire. We're not gonna do 50-50 for these. You can always access the PowerPoint on Blackboard so you can very slowly go through these on your own and see some of the little tips, tricks, videos, and images that I've posted in this PowerPoint so you can get an idea of why these are the right answers. Okay, number 1, our answer here is B, Hagar. Number 2, our answer here is going to be B, modified lazy left lateral. Number 3, our answer is B, radical hysterectomy. Number 4, the answer here is going to be C, tubal ligation. Lots of options to look at for tubal ligation methods. Number 5, the answer here is B, the CO2 laser. Number 6, our answer here is going to be C, a morcellator. Number 7, our answer is D, oxytocin. Number 8, our answer here is going to be A, 0.9% sodium chloride. You don't want to use that when you're using monopolar cautery. Number 9, our answer here is D. Talked about this in our A&P review, marsupialization. Number 10, our answer here is going to be C, povidone iodine. You never want to use anything with alcohol in it around mucous membranes, including the perineum or the vagina. 11, answer here is C, the perineal nerve. I'm going to say that a little bit better. Peroneal. I do that to myself sometimes. Peroneal. That way I'm not confusing with the perineum, that skin bridge. Peroneal nerve. I have to catch myself sometimes. Number 12, our answer here is D, Robinson. Number 13, our answer here is A, cerclage. Number 14, our answer here is A, indigo carmine. And number 15, our answer here is B, salpingostomy. Good. Okay. Last section, we're doing equipment sterilization and maintenance. So answer numbers 1 through 15. You're going to pause when I say pause. Go about the answers on your own. Make sure you do your test taking strategies. When you're done with numbers 1 through 15, press play. We'll review our answers. On the count of 3, 1, 2, 3, pause. Welcome back. Okay, again, we're going to do rapid fire through these. Number 1, our answer here is C, reposable. Number 2, our answer here is B, enzymatic detergent. Number 3, our answer here is Geobacillus, I have to say it so slow, Geobacillus stearothermophilus. Oof, it's a mouthful. Number 4, the DART test. The answer here is A, dynamic air removal steam sterilizer. Number 5, our answer here is C, spores. Number 6, our answer here is B, flat. Number 7, the answer here is D, 30 minutes. And this is from your textbook. If you'd like to go through the drying times, the exposure times, they also have a table, I believe it's table 10.2 for pre-vacuum steam sterilization for times. Okay, number 8, our answer here is B, liquid peracetic acid sterilization, also sometimes referred to as a STERAD. Number 9, our answer here is D, stylet. Number 10, our answer here is cavitation. Write this down. Our access code for Module 4 Path Certification Review Session Week 4 is 808022. Again, the access code is 808022. Okay, answer for number 11 is D, an open position. Number 12, our answer here is D, 25 pounds. Number 13, our answer here is B, Tyvek packaging materials. Number 14, our answer here is A, blood pressure cuffs. And 15, our answer here is A, neurosurgical instruments. I appreciate you guys being here with me today. If you guys have any questions, comments, concerns, please reach out to me via email, phone call, Blackboard message. Have a great rest of your day. Thanks so much.